Hi, everyone. Welcome to today's session of Healthy Discussions. Before we get started, I just have a few housekeeping notes to share. The chat box and Q&A feature are both open, so please feel free to use those. You can turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And this session is being recorded and will be posted to Quality of Care NL's YouTube channel at a later date. First, I'd like to acknowledge that we're joining you from the ancestral territory of the Beothuk, and the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and to take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University, aimed at improving social and health outcomes in our province. Healthy Discussions is our webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning health and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning health and social system as defined by Health Accord NL in its task force report. This definition might seem a little complicated the first time you read it, but what it really boils down to is a health and social system that continuously learns and improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. And you'll see that part of that definition also states that individuals and families are active participants in all elements. So by engaging in sessions like this one, by being an active participant in your own healthcare and wellness, and by talking about and acting on issues that impact us as a society, you are contributing to a learning health and social system in our province. June is actually Seniors Month in Newfoundland and Labrador. So today our discussion will focus on the topic of an aging population. We're delighted to have joining us Dr. Allison Pridham, who's an internal medicine and geriatric medicine specialist at NL Health Services, as well as a clinical assistant professor at Memorial University. Dr. Kayla Furlong is a care of the elderly resident at NL Health Services and clinical assistant professor of emergency medicine at Memorial University. And Natalie Reardon, who is director of strategic health networks, specifically the health of the older adult at NL Health Services. Joining them for today's discussion is Quality of Care NL Manager, Robert Wilson. So Robert has some questions to get our conversation started, but we will also be taking questions from the audience. So please feel free to type your questions in the Q&A box or the chat throughout our presentation. And since today's discussion is being recorded, you may wish to ask your question anonymously, which you can do by using the Q&A box instead of the chat box. So I'm going to stop sharing my screen here now and throw it over to Robert to get started with our discussion.
Perfect. Thanks, Melissa, and welcome our very prestigious panel here now. So without further ado, I'm going to get things started. Natalie, I have a question for you. You are the director of a strategic health network. Can you actually tell the audience and myself what is a strategic health network and what is the purpose of these networks?
Absolutely, and thank you so much for inviting me in this discussion today. Strategic health networks are intended to be integrating mechanisms in our new provincial structure within NL Health Services in order to ensure consistency and standardization across all 5 zones regarding the quality and standards of care that we provide in this province. Each strategic health network is designed to focus on a specific area to drive system improvements to achieve better health outcomes for patients and their families. Each network is supported by a medical dyad, as well as a team including planning specialists, evaluation consultants, administrative supports, and quality improvement leads that support the overall planning and improvement efforts that we embark on. Our strategic health networks are interprofessional groups with a provincial scope and mandate, really, and we work collaboratively to drive those clinical and operational improvements in health outcomes and service delivery. Strategic health network memberships may look different depending on the network and its level of maturity, but it can include health leadership, providers, physicians, academic partners, government and community partners, as well as patients and their families. And currently there are 4 strategic networks in place at NL Health Services, which includes primary care, emergency department, surgical services, and health of older adults, which I am honored to lead as director.
So that kind of leads me to my second question. There's a network set up for older adults. Can you kind of tell me about the work that this network will engage with?
Sure. Well, our networks are still early days, and strategic health networks are new to Newfoundland and Labrador Health Services structure. So part of the work to date is building those strong processes to support engagement and transformation efforts around priority areas that affect the health of our older adults. But I think one of the best ways of understanding the type of work that we will engage in is perhaps to share some of the work that we have accomplished to date. So during the early phases of establishing our network, we have focused on the recommendations of the Health Accord and provincial priorities to advancing the quality of care we provide to older adults. One of our early wins as a network is being selected to participate in Healthcare Excellence Canada Enabling Aging in Place Collaborative. Phase 1 of this collaborative was really to identify an innovative approach or leading a practice that supports older adults to remain in the community and reduce admissions to long-term care. By engaging our network, we selected Mount Sinai Hospital's ACE strategy, which stands for Acute Care of the Elderly, and they've achieved some pretty impressive results throughout their 14-year ACE journey. The model that Mount Sinai has developed has been recognized not only nationally, but internationally as well, and we felt that our province would greatly benefit from its adoption. As part of this collaborative, our network participated in 5 virtual coaching calls with Dr. Sinha and his Mount Sinai team to really understand their model, their lessons learned, what made it work, and to explore how we can adapt it to Newfoundland and Labrador. We also hosted a series of ACE planning events in all 5 of our health zones to identify the existing strengths and opportunities to build upon in order to advance our ACE strategy. Although our network is new, we have achieved some significant milestones as a team, which I believe highlights the type of work that our network will engage in and will continue to do so. We have created senior-friendly order sets to support ACE, which we are hoping to spread across our acute care system. We actually brought together our geriatricians and care of the elderly physicians from all zones to develop and approve these order sets, and I think that's a pretty incredible accomplishment. We've also implemented an electronic comprehensive geriatric assessment for our ACE unit in Western Memorial Hospital that opened June 2nd. And what's so significant about this is that it pivots away from the previous 90-minute paper-led process that was being completed by our geriatricians, and it has shifted to an interdisciplinary team approach that not only enhances quality of care, but it improves capacity for our geriatricians. We also built an electronic daily rounding tool for ACE, which focuses on quality of care on the unit, such as whether or not patients are screening positive for delirium, whether they have catheters, are they developing pressure ulcers, are there any falls? And this relentless focus on quality will ultimately lead our team to achieving better health outcomes on those units. And finally, our strategic health network has developed a comprehensive evaluation framework to monitor and evaluate our ACE journey so that we can ensure that we're achieving the results that we are anticipating on achieving. Using research and data to inform our conversations is critical to building a more dynamic and responsive care system for older adults across our province, and I'm pretty excited to be part of this journey.
It's good. It sounds exciting. You briefly mentioned recommendations that were coming from the Health Accord. So one of the recommendations that actually came from the Health Accord was establishing these centers of excellence for aging. So I'm going to pass it over and direct my question to Dr. Pridham. Can you tell us a bit about these centers of excellence for aging in the hospitals, which will hopefully lead to improved quality of care? So can you kind of tell us what these centers are all about and what is the plan to establish these?
Yes, absolutely. Thanks for having me today. So yeah, absolutely. As you stated, the Health Accord highlighted, some areas that we as a province need in terms of healthcare development, and one of these was senior healthcare. And so in talking about that and how to implement that, the recommendation has been made for these centers of excellences. So this is across the province. We're all under one health authority now, but really there are these sort of hubs within different jurisdictions that we are going to bolster and create teams there to try to enhance care for older adults, and specifically frail older adults. So adults who are vulnerable, have some sort of functional decline in the community. These healthcare systems are not limited to the hospital, because we also work, in the community as well. And these centers of excellence will help support community initiatives as well as in hospital management. And really what we're focusing on is the creation of these frailty pathways. So how do we, number one, identify older individuals who are in need of some of these services, who, have frailty, some sort of functional decline. How do we identify them, starting early on? So their first interaction with the healthcare system, which, typically could be an emergency department, which Dr. Furlong is going to speak on a little bit more, to my understanding. And then, how do we identify these patients, do a comprehensive assessment? So not only with medical professionals, but also with interdisciplinary teams, and to try to see if there's any factors, anything that could be optimized or potentially reversible, and how to get them connected with the appropriate resources and figure out a plan. So, if that plan and their trajectory is to be admitted as an inpatient to the hospital, how do we support that? And Natalie's done a good job at highlighting some of the work that's already been done there in different regions. And there's upcoming developments, not only in the Western zone, but here in Eastern as well, with the creation of acute care of the elderly. That's sort of our inpatient unit and proposal. I believe I'll be speaking a little bit more to that afterwards, but, making sure that there's senior friendly principles of care for inpatients. And then if, your trajectory is maybe you don't need to be admitted to the hospital, how do we optimize things in the community and set you up for success there? So connect you with the right resources, have appropriate medical follow-up. And that includes, so I'm a geriatrician internal medicine specialist. We also have colleagues in family medicine who have upskilled in care of the elderly training. And so we rely on them a lot, especially in the outpatient setting, to help with, there's collaborations with collaborative team clinics and interprofessional development there. So that's sort of the healthcare hub. And then there's also the additional training for family doctors, which I sort of mentioned, and upskilling of, family medicine residents, and upcoming plans to upscale specialists as well, with fellowship programs. So a lot of exciting things kind of happening. These centers of excellence do look a little bit different, just depending on resources in different zones, but there's experts in all of these zones, and we're working very closely with them to figure out what is appropriate for that region, and how to grow from there.
Excellent. That sounds exciting. So yeah, I'll direct my question now to Dr. Furlong. And Allison, you previously mentioned this about senior-friendly emergency departments. So part of the Centers of Excellence is establishing these senior-friendly emergency departments. So Dr. Furlong, can you kind of walk us through what is a senior-friendly emergency department and some of the unique aspects of that?
Sure, yeah. So thanks for having me. And again, Melissa mentioned that I'm a care of the elderly resident. I'm actually an emergency physician as well. So I just did some extra care of the elderly training that Allison just mentioned, to try and bring back some of those geriatric skills to the emergency department, where typically the care of seniors has been lacking. So a senior-friendly emergency department can be anything from the people that you have, your staff, to education, to the physical space that you have. So as a part of Health Accord, of course, one of the recommendations was to make senior-friendly emergency departments. And other provinces have been doing this for a number of years already. And there are, specified guidelines that exist to help, a health authority develop and get your emergency department more senior friendly than what it currently is. So the plan is to use those guidelines to help modify our current emergency departments or build new ones in certain areas in order to improve the care. And as I said, so it does include things like staffing, so having the right people, and part of that is an interdisciplinary team. So historically in the emergency department, there were, physicians and nurses. However, for senior friendliness, that would include, specifically trained geriatric nurses, physiotherapy, occupational therapy, additional social work and discharge planning liaison resources that would all work together to try and figure out the right plan for a senior that comes in. It also involves, quality improvement. So we're hoping that Natalie and her strategic health network can kind of help with that aspect so that we can improve as we do implement these things in real time, and making sure that you have policies and procedures that are appropriate and specific for older adults. So it's a combination of things.
So you mentioned perhaps changing the actual physical environment. Could you perhaps give a few examples of how an emergency department's physical environment could change to make it more senior friendly?
Yeah. So, the hospitals that we currently have been designed a number of years ago, and the emergency department historically has been designed to treat acute issues, meaning something, like appendicitis or a heart attack, those kind of things. But we're seeing more and more as older adults and seniors present to the emergency department that their presentations are more complex and not as straightforward anymore. So part of that, getting assessing the senior better would be changing the physical environment. So things like bigger rooms, private rooms, avoiding 4-bed wards, which has a lot of noise, no orientation to light or space or time. And those things can lead seniors to have delirium or be more confused when they do arrive. Even simple things like, having a clock, orientating yourself to time, having more chairs at the bedside for family members. Typically, there's none, or maybe one if you can find one in emergency departments nowadays. And then appropriate wayfinding, so signage, bright, large numbers, and then having appropriate equipment. So if someone has forgotten their hearing aids, we have special devices that we can use. Appropriate chairs and toilet seats, as well as non-slip socks, for example, that can help prevent falls.
Excellent. So Melissa, I'm going to kind of chime over to you and see if there's any sort of questions coming from the audience.
Yeah, sure. We have a few coming in already.
Okay.
This question is for Kayla. One of our audience members wants to know if there's a difference between urgent care and emergency care in terms of the facilities. And I know we've talked about that a little bit here in this province recently with some different healthcare announcements, but can you maybe touch on the difference between the term urgent care versus emergency care?
Sure. So emergency care is your typical emergency department that we've had for a number of years, and the plan is to make those more senior friendly. So that concept won't change. We'll just simply be enhancing the care that we provide there. The urgent care setting, which is something novel to our province, is something in the works. And there's some facilities that have been selected across the city to provide urgent care, which is something in between your family physician or a walk-in clinic and then the emergency department. So you would go to urgent care for issues that, you would need to be seen right away, but might not necessarily, need an ambulance or need specific emergency department care. At those urgent care centers, there are plans to have blood work, X-ray, and certain other modalities that could be done in that setting. So it's kind of, something, like I said, in between, the clinic setting and the emergency department setting. And we do have plans. I've been discussing with the urgent care team to ensure that those spaces are senior friendly as well.
Thanks very much. We have time for another audience question, Robert, before we
Yeah,
move on?
sure. Sure.
We did get a lot of questions submitted on registration from some of our participants, and a lot of them focused on how we can make it easier for seniors to age in place so that they remain in an environment that's comfortable and familiar to them, whether that be at home or with a family member. Can any of you comment on the importance of that type of aging in place environment for seniors as we age?
Yeah, I can speak to that a little bit. So in my clinical role now, we have a lot of outpatients, and we work a lot with seniors who are at home and wish to stay at home, and that's always our goal. As people are able to, there's limitations with that, of course, and everybody's situation is different. But we certainly, work with patients and with families to try to keep people at home. Traditionally, there has been a lot of barriers here in the province around that. So, lots of barriers include the resources that are available. So access to things like home care or, specialized care for allied health in terms of older adults. And then also, access to medical professionals and having the treatment plan and the support to stay at home. There's been a significant investment from the government and plans to invest over the short to medium term future to kind of invest in all of those aspects. So there's lots of plans underway to help bolster that support system for older adults who want to age in place at home, to let them be able to do that and have access to the types of resources that they need, because there's definitely challenges right now. So we're seeing a big investment there.
Anything else, Melissa? I think we still have time if there's any more questions.
Yeah, one of our questions just came in as you were talking, Allison, about how existing home care programs collaborate with this strategy, or if they're involved in working on these aging in place initiatives. Kind of the current model of home care as it exists in the province right now.
Yeah, and that's part of the area of investment, I'll say, is, how do we work with, social work is really tied into their home care agencies, and, with plans to, expand those, support those well, and making sure that people have, there's talks of education in those areas too, to a lot of the users of these home care agencies and systems are older adults. So, implementing educational strategies there as well to help with the people providing this type of care as well. Yeah.
Perfect. Thank you. I'll send it back to you, Robert.
Okay, perfect. Thanks, Melissa. I'm going to pick on you again, Dr. Furlong. So on the topic of senior-friendly emergency departments, how can they potentially, or from research perhaps, impact a patient's health outcomes?
Sure, yeah, so I can speak to that. So of course, as Allison mentioned, the goal is to kind of age in place, and there's lots of consequences of visiting a hospital. But if you do have to go to one, the goal is, of course, to make those facilities senior friendly. They exist and they've been studied, and the evidence suggests that they do work. There's been a number of randomized controlled trials as well as systematic reviews completed in other areas of North America and the United States. So some of the things that they look at when they're looking at these outcomes of how successful a senior-friendly emergency department can be is length of stay in the emergency department. So if your emergency department is senior-friendly and you have that appropriate interdisciplinary care team, they can figure out the disposition or where a patient needs to go quicker than historical emergency departments have done. Some of the other data that they look at is reducing the need for hospital admission. Just because you do end up in an emergency department doesn't necessarily mean that you do need an admission. And sometimes there are risks, like I mentioned, associated with that. They also look at, if you've been seen by an interdisciplinary care team in the emergency department, does that reduce the number of times or revisits that you end up, coming back or bouncing back to the emergency department? So those are just a couple of examples of, objective outcomes that they look at to see if they're working.
Okay, and some of these metrics, will you be kind of tracking these as these senior-friendly emergency departments start popping up?
Yeah, so that's the plan. Certainly it's that in itself is a large undertaking, so we'll need to kind of build resources and funding and teams to help us with that. But there are currently quality improvement teams within NLHS that we plan to collaborate with to kind of help us along the way. But I think, it will be important to figure out, of course, the data exists elsewhere that they work, but we want to make sure that what we're implementing, is working locally. So yeah, we do have plans for that.
Perfect. Dr. Pridham, I'm going to pass it back over to you. Natalie previously mentioned within these strategic health networks is the establishment of these ACE units, acute care for the elderly units. Can you kind of elaborate on what these units are and perhaps how they differ from your typical acute care unit or hospital setting?
Yes, definitely. So acute care medicine is an area that I work very often in. These acute care of the elderly units exist across Canada and internationally. We are coming into it with a lot of data and a lot of knowledge from other places in terms of, what's needed here, what we need to implement, and how to do that effectively. So older adults, as Dr. Furlong has said, there's challenges with coming into the hospital and risks associated with that. So the goal of these acute care of the elderly units is really tailored to best practices for older adults to try to reduce that risk and, lots of different risks, but really we're talking about functional decline, that can be associated with hospital stays or delirium, so like acute confusional states when people come into hospital. And I'm sure if anyone has been unlucky enough to have an older loved one in the hospital, you can relate to that because it is very common for older adults, unfortunately. So there's a lot of evidence around how do we structure inpatient units to create a setting and an environment where we reduce these risks. So, and also as Dr. Furlong has highlighted in the Emerge, there's a similar sort of structure up on the floors in an inpatient setting where, the physical space needs to be optimized first. So things like having more private rooms, be like a lot of the things that Dr. Furlong mentioned, like orienting people to the time and the place, having enough room to sort of mobilize when they need to, clearing. There's a lot of clutter sometimes in the hospital, so making sure that the physical space is conducive to recovery and healing. And then when you talk about personnel, having appropriate ratios of, nursing staff or PCAs to patients, as well as having a full complement of an allied health staff. So occupational therapists, physiotherapists, dietitians, speech language pathologists. I'm sure I'm missing a few people, social work. We really utilize this interdisciplinary team and take that approach where we use everyone to their full scope of practice. And then kind of tying everything together would be, doctors that are trained not only in internal medicine, but also in geriatric care. So people who have gone away to do extra training in geriatric medicine, and kind of having them, putting everything together and figuring out a treatment plan going forward. So there's a lot of evidence around best practices for older adults. There's a lot of like behavioral, structural things that we will do, as well as medical things like medication reviews, proper workup for people with cognitive decline, those types of things. So like lots of things to get, lots of things go into it, but that's kind of overarching sort of the principles of that.
So in essence, almost establishing a senior-friendly hospital,
Yeah, exactly. And
Would that be the ultimate goal? Like for the culture of something to be senior friendly, to diffuse not only onto these ACE units, but into the entire hospital setting?
Yeah, absolutely. And we've already done a lot of work in terms of, trying to implement these certain practices hospital wide. But, the real gold standard would be to have, a concentration of these resources for people that are appropriate, because not everyone would need these specialized services. So, we have implemented some, Natalie referred to, certain order sets. So like things that are senior friendly throughout the hospital for like hip fracture patients or surgical patients or post-op patients, right? So we've implemented those already, but really having this like hub for patients that are appropriate for that level of care is really the gold standard internationally.
Perfect. Melissa, I'm gonna hop over to you to see if there's any more questions coming in from our audience members.
Yeah, sure. The chat box is really active.
Okay.
We've mentioned a couple of times the idea of all of this work to achieve better health outcomes for seniors. And I guess there's just a little, you generally understand the term better health, but what would be some of the more specific things you'd be looking for, indicators that in the elderly population, their health has improved? Is it things like less incidence of chronic disease, or what would be those indicators for better health in the senior population?
Yeah, so I think that really depends on what kind of a setting you're looking at. So, I just spoke about acute care settings. So there's lots of indicators there that, that some of the things that we've implemented have been working. So things like rates of delirium, looking at functional decline, looking at, where did they come from coming into hospital? Are they able to be discharged there? So are they going back to their home or a personal care home? So there's lots of things that are specific to sort of in hospital. And then a lot of things that are specific and within that, also like representations to emergency and readmissions, because ideally, seeing people, we could figure out a management plan to, again, help people stay at home and reduce their interactions with the healthcare system in an acute care sort of setting. And then, being at home or, longer term management of things, there's, we tend to look at a little bit different variables. We do look at chronic disease and chronic disease management, but really, we look at things like quality of life, functional ability. So maintaining function and improving quality of life are big metrics for us. Reducing burdens of medications or, side effects of medications, those types of things. So it really depends on your setting, but there definitely is a little bit of a shift where, we're talking about not only like longevity of life, but also quality of life and maintaining function and what's important to people and how do we help them with that.
Natalie, did you have something you wanted to add there?
No, Allison did a really great job at iterating a lot of the data. I was only going to highlight, and previously I meant to mention it as well, some of the indicators like that we are tracking for success on like the ACE unit, for instance. A big part of that is their overall experience on the unit, but what we're looking to also explore is that transition home, which is so important to enabling older adults to age in place. So we have plans in place once home to capture their experience with that transition, whether they felt supported in it, did they have the appropriate supports and resources that they need, and really exploring what maybe some of those gaps may be and how we can enhance some partnerships in community, which I believe is really critical to really supporting our older population to age in place. Our healthcare system is so busy and not always the most appropriate place. So it's really critical through these networks that we do build those partnerships and explore innovative ways of doing things different in order to transform our care delivery.
Yeah, that's true for sure. Another one of our audience members asked a question, talking a little bit more about care in the community, about improving access to services like physiotherapy, especially in rural areas of the province, that can help older people maintain their mobility and their balance and some of that things that contribute to their independence while aging in place. I know it can be difficult, certainly, for certain of those specialty type services to be accessible all over the province because we have such a rural population, for sure. But do you have any indication of the benefit of those types of services for seniors? Anybody?
Yeah, we've started some initiatives. I think, there's two sort of challenges there. So one is, declining mobility in an older adult at home, and how do we, utilize our interprofessional team to sort of help with that. So, in a setting that's more urban, we have started some initiatives with like reallocating certain resources to help with like physiotherapy, home visits, occupational therapy. So those are kind of in sort of pilot stages now, but definitely we are working towards that. I practice in the Eastern Zone in an urban setting. So, I think once some of those practices are established and run well, and we've kind of ironed out some of the details, absolutely our goal is to kind of expand that more rural. But there's definitely a lot of challenges with healthcare system delivery. Going back to my first sort of question that I had in terms of these centers of excellence is, there's sort of a tiered approach. So, having the centers of excellence being in some of these urban hubs, but then also having these sort of satellite locations where, it might not be a huge urban center, but, there's a collaborative team clinic or a clinic of family doctors in a more rural setting where they could be supported with, care of the elderly, family medicine physicians who have upskilled there, and then also bolstering that team with like allied health, such as physiotherapy. So there's a lot of like, we talked a little bit about, where we kind of these bigger centers, but there's also work ongoing in rural settings with these sort of smaller centers, but ultimately, being connected with the bigger centers as well, and these smaller centers being resourced and staffed appropriately, and the education being provided there too.
Thanks very much. Robert, did you want to move along with your questions?
Yeah, sure. So I kind of have a question for anyone to chime in here. The provincial and federal government just made a big announcement last month. They are providing funding, I think around $78 million to the residents of Newfoundland and Labrador for essentially just an aging in place initiative. And forgive me if I've read off this list for what the plan includes. It includes improving home and community care systems, enhancing palliative and end-of-life care, strengthening the workforce, and enhancing the quality of care and quality of life through improved long-term care standards. So how can you see this funding announcement benefiting the quality of care of the residents and the initiatives that you guys are engaged with? Anyone?
I mean, I can start, certainly very high level, kind of goals at this point. But, the first one there, improving home and community care services. Prior to my life in the emergency room, I was a family physician, and we're certainly lacking in that area. And Dr. Pridham alluded to it as well. So improving, the workforce of family physicians, nurse practitioners, physiotherapy, occupational therapy, home care. All of that needs to be enhanced by numbers and by quality of care that we're providing. So I think, that's one of the huge first steps. And that helps, down the line. So downstream, if those services are improved, you presumably would less likely to need to go to the emergency department in a crisis, and we could stay home and less likely to be admitted as well. So that would be a huge big first step.
Yeah, and just to build on what Dr. Furlong has said, this is a big influx of money and resources into this area now that we work very closely in. And that it's not something that has traditionally been invested in the past in Newfoundland. So we're in a little bit behind the ball in terms of timing wise, but using that to our benefit to see, you know, what exists out there, what's working, how do we implement that in Newfoundland and Labrador. And so, you know, all of those things highlighted, you know, like that's a large sum of money for the next little while. And we focused, you know, individually, there's different working groups kind of working in all of those areas. And again, I think I keep going back to frailty and functional decline, and how do we set people up on the correct pathway. And I think that's kind of like overall, you know, what we kind of go back to with older adults is how do we set people up with the correct resources, get them on the right trajectory, optimize their functioning and their medical needs, and going from there. So everything that we're doing kind of goes back to that, and optimizing people's quality of life and function.
Right, and I guess just under the umbrella of strengthening the workforce, I mean, this is not a question, but it is pretty exciting news, is that it looks like they're establishing a fellowship program within the Faculty of Medicine for geriatricians, which is kind of exciting, right?
Yeah, definitely. So as of right now, there's 4 Royal College internal medicine geriatricians, 3 in the Eastern Zone and 1 in the Western Zone. All of those physicians are, so I myself am one of them. So I'm very familiar with the process. So we, you can do internal medicine training here in Newfoundland. And I think most people, maybe with the exception of one, everybody is from Newfoundland and wants to come back. So it's always been an option to do internal medicine training here, but then you've had to go away for a couple of years. It's a 2-year fellowship for us. So, you know, the development of a training program has multiple positive effects. So it's good for all trainees that kind of are here, no matter if you're in internal medicine or family medicine or surgery. We have a lot of people rotating through internal medicine. So the exposure to a lot of different disciplines who rotate through, but then specifically people who are really interested in geriatric medicine, they'll have an opportunity to train here. And then, you know, the result of that, if we don't train people here, it's very hard to recruit people here to work in that area. So being able to train doctors that are from here and want to stay here and want to contribute to the health of our population, it's going to be critical, setting up this training program. So we're all very invested and involved with that, and it's a very exciting endeavor. Excellent.
That is very exciting. I got one more question here, but before I ask that, Melissa, I'm going to pass it back to you one more time and see whether or not there's any more questions for our guests.
Yeah, sure. I've seen a couple of comments come in, specifically asking about I guess what we would call IDEA principles, IDEA standing for inclusion, diversity, equity, and accessibility. So asking about considerations for seniors who are neurodivergent, seniors who have sight loss or hearing loss, seniors who maybe do not have secure housing. And a couple of other examples were mentioned as well. So I'm just curious how the idea of equity, diversity, inclusion, accessibility, and engaging with these types of groups that may be historically underserved or underrepresented has factored into some of the planning and work that we're planning to address our aging population and improve care for the elderly in our province.
Yeah, I can speak to that a little bit. So, you know, definitely challenges. And I think that those are challenges that are not just specific to senior care, but just overarching in terms of, you know, challenges within the healthcare system, period, no matter if you're 20 years old or 70 years old, right? And I think the Health Accord sort of deals with that on a bit of a larger scale in terms of talking about things like social determinants of health. And, you know, I think that's even like a broader scale. Like certainly we do encounter those on a fairly regular basis, and there's challenges there, but I think that's even beyond the scope of, you know, our current practice in terms of how to set these systems up in a more general setting where people can be supportive if they come from a different background or share their unique set of challenges. You know, every case is a bit different. I've personally worked with like housing developments. Like we sort of reach out now on an as needed basis when we have patients who need those services. Yeah, it's definitely an area that is expanding, and I think is expanding on even a larger scale than just senior healthcare. And the challenges don't go away as people age; they're certainly still there. So I think that's a bit of a work in progress, maybe a little bit even broader scale than what we're kind of focused on here, but definitely still something to consider and have in mind. And we will definitely continue to connect with these people and use that going forward too.
To build on what Dr. Pridham, just spoke to, that is the beauty of these networks, is that we do engage with our partners, and that in everything that we do apply that lens of who are we serving, who are we not serving, and how do we provide culturally competent care, and how do we look at the determinants of health and how they impact access and care outcomes. So those are always part of the conversation that we do have when we're planning and rolling out new initiatives and looking at things. And our networks are new, and that is going to be, we're continuously going to be looking at like what other partners can we be engaging in this conversation to ensure that no one is left behind and that everyone feels supported with our healthcare system.
Right, just kind of breaking down the silos.
Yeah.
Right. Melissa, is there any more questions?
Yeah, I do want to share one comment from someone in here. Seniors, family, and service providers are welcome to call Seniors NL, which is, of course, a great organization in our province and a great first point of contact. There's been other comments earlier about people who work directly with seniors. Oftentimes they hear that they really don't know who to call first or where to go to find the information and the services that they need. So Seniors NL is a really great organization that you can contact for details about home care access, assessment, subsidies, any kind, a multitude of other resources that seniors might be looking to access. They posted the phone numbers there in the chat. And I'll also, in a minute, also add the website, but I'm just going to repost those phone numbers for Seniors NL so that people know that resource does exist for them.
Well, that kind of leads into the final question that I have for our guests is that, I mean, we've been focusing mostly on the acute care setting and sort of the health aspect, but there is a lot of social initiatives that are happening across the province. In particular, the establishment of these age-friendly communities, which is not new to a lot of these. I mean, like the likes of like the town of Clarenville have been sort of the poster child for not only within the province, but across the country and even globally that they've kind of put that senior-friendly initiatives on the map. I'm just wondering if you guys have any comments on how these senior-friendly environments, senior-friendly cities and communities can help one's quality of life and perhaps a better trajectory on their health outcomes.
Yeah, and I think, as we've said, focusing on, putting resources and understanding the importance of people aging in place and aging at home, that's the goal of some of these things. I'm as a physician, I tend to talk a lot about the medical side of things, but I think more and more there's even more evidence that details the importance of not only medical care, but also some of the things that these types of communities would really excel in, and that's engaging your body and your mind, engaging socially, engaging physically, being able to get out and go for walks as you're able to, making sure that loneliness is a big thing that contributes to cognitive decline, right? And as well as your mental health and overall well-being. So we can't forget about those types of things as well. So I think that does a really good job at focusing not only on the medical side of things, but also everything else that is so important that goes into your well-being, and that also directly does impact your health. There's lots more studies out now talking about exercise and how that benefits your mental health, just as well as some medications in certain instances. So, making sure that you're socially engaged, physically engaged. I think that's really excellent initiatives that focus on, or that as one part of what they focus on, being able to optimize that for people.
Right, and like I mean, it's all kind of coming together here. Is that like Seniors NL is actually, have an initiative right now in collaboration with our regional health authority about social prescribing. Where perhaps it can combat some of this loneliness and isolation. So we're excited to see what comes of that. Does anyone have
Robert,
any?
we're thinking on the same wavelength there, because I was going to throw a next question to you
Okay.
about, explaining a little bit what social prescribing is, because we learned about it on our last healthy discussions, which
Right.
involved Seniors NL and a couple of others from NL Health Services to tell us about the concept of social prescribing and how it does impact our health. Can you just quickly summarize, you think, what
Yeah, I
is
mean,
social prescribing?
essentially, it is almost just like a prescription. If someone goes to see, the idea of social prescribing would be someone going in to see their healthcare provider, and that healthcare provider can acknowledge and see that this person perhaps would benefit in something within their community.
So a
And
prescription for something non-medical.
non-medical, it would be something like yoga class or going to bingo, something within that community, and having that linkage with Seniors NL who have a great concept of all those programs within the communities across the province. It's a great partnership, and I'm excited to see what comes of it. I don't know if anyone else has any comments, Dr. Furlong or Natalie, whether you have any further final thoughts on what we've discussed today before we wrap it up. All good?
Robert, I just have one more comment in here.
Yeah, sure.
The project with Seniors NL that's focused on social prescribing is aiming to have a role in our new family care teams called a link worker. The role of that person would be to link people with some of these different types of services that they can find in their community that might help them in whatever it is they need to improve their quality of life, whether that's access to meal programs or, like you said, social programs where they can get out of the house and interact with other people. So the role of that link worker, I think, going forward would be very crucial to definitely some of the people in our province who are working on figuring out how to age in place and keep their quality of life up as well. There's lots of different, one of the comments in the chat talked about some of these different programs and services in the community that are provided to seniors in their own home or in the, they're talking about things like foot care, meal programs, transportation options, blood or urine collection, where the person doesn't necessarily have to come into a clinic or a hospital setting to do those types of things. And how they, linking with all of these types of businesses, even snow removal and lawn care, all of that type of stuff can definitely contribute to how one would age in place and keep their quality of life improved at home. For sure. And I think, yeah, the social prescribing initiative and the link workers will definitely contribute to that for sure.
Perfect. Thanks for that, Melissa. And before I hand it over to you to wrap it up, I personally want to thank our guests here today, our panel, Drs. Pridham, Dr. Furlong, and Natalie, for leading us in such an important topic right now, and it's great to see that it is an important topic right now, and that there's actual direction and going towards such an important thing within our province. It's great to see that you guys have such a passion and knowledge for this. It looks like our healthcare system is in good hands with you guys. So without further ado, Melissa, I'm going to pass it over to you to kind of wrap things up here for today.
No problem. So I'll just echo what Robert said in thanking everybody for joining us in this discussion. It is definitely an important topic, and you can tell by a very active chat room that we've had today that a lot of people are interested in it for sure. And just a reminder to all of our attendees that the recording of this session will be up on Quality of Care NL's YouTube channel in the coming days. And you can also check out recordings of all of our previous sessions there. as well, including the one we mentioned on social prescribing. And lastly, you'll see a very short post-event survey on your screen after we end the webinar. So we'd appreciate any feedback you'd like to provide or suggesting ideas for future healthy discussions. So thank you again to everybody who joined us today, and I hope you have a great rest of your day.
Thank you so much for hosting, and thanks for having us.
Thank you, Natalie.
Thank you for having us. We appreciate it.
Thanks so much. Bye-bye.